Okay, well, good afternoon and welcome to the AFSPIL Research Connection. We host this special event 1 to 2 times a year. And really the purpose of it is for our constituents to hear from an AFSP funded researcher and hear about their specific line of work and what they're learning about suicide prevention, whether it's in a specific population or just generally about how we can help prevent this loss of life. So today we do have Jody Russin with us, and she will be introduced in just a moment. But just want to do a couple quick housekeeping items. If you do have any questions, at the bottom of your screen, you should see a chat option. Go ahead and put your questions or comments in the chat. We may get to them as the presentation goes on. Otherwise, Meg and I will be managing them throughout the presentation and probably holding them until the end. And if, at any time you are feeling that this is triggering or you're having a tough time with the presentation, please go ahead and, step away if you need to. We want to make sure you take good care of yourself. And I forgot to introduce myself. I'm Courtney Collins. I am the Regional Director of the Illinois chapter of AFSP. So very happy to have all of you with us today and appreciate you taking the time. And I'll pass it over to Meg to do the introduction so we can get started.
Hi, my name is Meg Graff. I have served on the Illinois board for 9 years now. And this is one of my favorite events to put on. I always leave feeling so hopeful with the new information. And I love that we're able to share that with our constituents. This presentation is especially meaningful to me. I have a huge interest in how we can support the LGBT community. And I'm so grateful for Jody's presentation and what she's going to share with us. Jody works at Virginia Tech, and she's going to be talking to us about attachment-based family therapy in the LGBT community.
Meg, thank you for that introduction. Yes, Jody Russin, she, her pronouns. Very nice to meet you all, and so glad that you can be here. I am going to go ahead and share my screen with you. Give me one moment, and I'll check in with you to make sure that you are seeing what you need to see. There we go. You all should be seeing the big slide. Is that right? Can you give me a thumbs up if you can? Okay. I see some nods, some thumbs up. We are good to go here. Thank you. So just to reiterate what Courtney had said earlier, we're going to be talking about psychotherapy today. We're going to be talking about treatment of suicidal thoughts and behaviors today. And so if anybody needs a break, if anybody needs to step away, I hope you all can do that. Attend to yourself during this presentation and make sure you're giving yourself a break if you need it. In addition, please feel free to put in your chats, your questions into the chat, and I'll get to them if I can during the presentation. If not, I'll spend some time with them at the end. And bear with me if you see me moving around. This is the time in the day when the sun comes through and hits me in all sorts of directions. And I love the sun, so I want to keep the blinds open, but it does require me to move around a bit. Okay. So what are we talking about today? We are talking about a form of psychotherapy, a form of counseling called attachment-based family therapy. And this is a type of therapy where we are looking to repair relationships, build the strength of relationships so that families can be what we call a safety net to adolescents who are experiencing depression and suicidal thoughts and behavior. And what we're doing in this research is adapting that type of therapy to meet the needs of LGBTQ+ youth in particular. And not only LGBTQ+ youth, but those who are presenting in centers serving LGBTQ+ youth. And I'll be talking with you a little bit more about the utility of that. But first of all, I want to go through our goals today and also talk with you about some background for this work. So my hope for us today is for me to give you a theoretical and empirical background of this work, why a therapy like attachment-based family therapy has specific utility for our lesbian, gay, bisexual, transgender, and queer youth. And I want to talk with you about some of the modifications of this therapy for the settings that serve this youth population. And then I want to tell you about some of our findings that demonstrate that attachment-based family therapy does indeed have some value for our services that work with this population. So one thing to note is, as Courtney mentioned in the beginning, a lot of the work I'm going to be talking about today has been funded by the American Foundation for Suicide Prevention, and in particular, the implementation project that's going to be at the center point. So let's start with some background. I am a family therapist. I'm a licensed marriage and family therapist. And so for me, understanding the system in which we live, the system, including our families, our communities, our societies, is really important for me when understanding individuals. And so because of that, I want to give you a thorough background of the scope of the problem and how we understand the problem that we're dedicating so much research effort to. So we know that suicide is the second leading cause of death for 15 to 24-year-olds. So suicide is a problem in our youth communities. And we know not only that those who are experiencing suicidal thoughts and behaviors, those who are making attempts, a very few people actually reach out and get mental health services. And this is particularly true in our youth populations. We also know that LGBTQ plus youth are particularly at risk for suicidal thoughts and behavior. This population reports higher rates of both ideation and attempt than heterosexual and cisgender peers. And so as a researcher, I'm always asking why. Why is it that our LGBTQ plus youth are reporting higher rates of suicidality? Well, when we think about this, we have to think about the context, the environment around our youth population. So we know that factors such as discrimination, victimization, family challenges, and rejection may lead our LGBTQ plus youth to experience lower self-esteem, depression, hopelessness, social isolation. And these factors can then lead to suicidality or increased risk for suicidality. And so for me, again, I'm a family therapist. I'm always thinking about the context around people and how that context influences the way we feel about ourselves. Now, I want to take a moment and focus specifically on transgender and gender diverse youth. That's the T in the LGBTQ. And I want to focus here because there hasn't historically been a lot of research focused on this population. But the research that has focused on this population has recognized that there's even a greater vulnerability for suicidal thoughts and behavior among transgender and gender diverse youth when compared to cisgender youth. And even more shocking is that we find that an estimated 30 to 50% of transgender and gender diverse youth attempt suicide during their adolescence. So that's not just suicidal thoughts and behaviors, which is significant, but it's also the attempts that make the risk so heightened in this particular population. And so let's think context again. We know that for our trans-identified youth, I say trans-identified as an umbrella term to include transgender, non-binary, genderqueer, gender expansive youth, we know that suicidality is linked to several factors. Internal factors like gender dysphoria, feeling like one's body or oneself does not match how they are on the outside, and internalized transphobia. I'm going to adopt the messages that I get about myself and my identity, and they become my own. So internal factors contribute to that. And also external factors, parental verbal abuse, peer verbal abuse, gender-based victimization, stigma, discrimination, rejection. These are all factors to consider when thinking about why there's such a disparity in suicidal thoughts and behavior when looking cross-population. So I also want to introduce you to two different theories that help us understand this public health problem a little bit better. And these are two theories that have grounded a lot of my research over the past years. And so I think it's important for you to be with me in understanding these theories before we talk about the research. Because as a researcher, if we're not grounded in our theories and have a semblance of ideas that help us put a framework into what we're looking for, we're kind of shooting around in the dark. So our theories really give us the pathway to putting variables together and making sense out of our findings. So some of you may have heard of these theories before, and for you, this is going to be a brief review, but others of you may not have heard of these theories before. So I want to talk with you about these two theories and then put them together in a way that makes sense for LGBTQ plus youth. So the first theory is the interpersonal theory of suicide, and this was developed by Thomas Joyner. This is significant because the interpersonal theory of suicide helps us understand that factors in our relationships and how we perceive other people are related to suicidal desire and contribute to hopelessness. So what Thomas Joyner discovered is that there were two interpersonal factors that were very much related to suicidal desire. And the first one was thwarted belongingness. Thwarted belongingness is our feeling that we don't fit in anywhere. Like no matter where we turn, we don't have a connection with others, or we don't have a sense of belonging in the groups of important people around us. So we're kind of isolated, we're on our own. The other one is perceived burdensomeness. So I feel like I am more of a burden or a pain to people than I am an asset or an important person. I bring people down. That's what I hear a lot of my clients say. I bring people down. People don't want to get to know me. Perceived burdensomeness is also another factor that has led to suicidal desire in Thomas Joyner's studies. And so when you put thwarted belongingness, I don't belong anywhere, and perceived burdensomeness together, I feel like I'm a burden to other people. And then I have an environment that habituates a person to pain and distress. That's what Joyner identified as this storm, this perfect storm for feeling suicidal desire and acting on that desire. And so what this research tells us is how important our perceptions are about how others feel about us. That our suicidal desire as people is not just isolated to something inside of us. It's very much connected to what goes on with other people and our social experiences. So speaking of social experiences, the other theory, minority stress theory, talks all about social phenomena. So what minority stress theory tells us is that when there is an interaction between stressors that are proximal inside of us, like for LGBTQ plus youth, perhaps internalized homophobia, or distal stressors, factors outside of us, like experiences of discrimination, that these stressors outside of us and inside of us, based on our minority status, shape our experiences and our expectations of other people. When we put these stressors together, they change the way we think about ourselves and the way we think about the outside world. And these stressors don't just come from nowhere, don't come from inside of us. They come from what society is telling us around us. And so that's where minority stress theory helps us to understand why LGBTQ plus youth may experience disproportionate rates of suicidal thoughts and behavior. So now what I want to do is put interpersonal theory of suicide and minority stress theory together and apply them to the way we think about suicidality amongst LGBTQ plus youth. So let's just start by saying that I think we all know that adolescence is a time of growth. It is a time of personal development. It is also a time when for our LGBTQ plus youth, kids are becoming more aware of their sexual orientation, their gender identity, their gender expression. And they also become increasingly aware of those distal stressors that we talk about. So discrimination, stigma, violence in their homes, their schools, community, and society. So as they develop more into who they are, they become aware of those unique stressors. We also know for some, not all, some of our transgender and gender diverse youth that around this time and the onset of puberty, that this can cause stress when one's body doesn't match how one feels they are inside, how one's gender is being felt. And so when we hit adolescence and the onset of puberty, we often find that some of our kids experience more gender dysphoria, that disconnection from how I look on the outside and who I am on the inside. And that can cause a lot of stress. And so when we have our adolescents developing and making sense out of how their bodies are being shaped, how their minds are being shaped, how their social relationships are being shaped, we find that exposure to these distal stressors may lead to more internalized stigma and distress. I'm being bullied at school because of how I express my gender. And so that leads me to feel like I'm not acceptable or I'm not valuable in my social relationships. My immediate family members don't understand why I'm dating someone of the same gender as myself. And so that might make me feel unaccepted in my home. And so as we experience these distal stressors, they become a part of how we understand ourselves. And so if we walk around in the world feeling like I may or may not be accepted by people around me, people are going to respond to me, perhaps with anger, violence, ambivalence, dismissiveness, that's going to change the way I show up in the world. I may not engage in the same way as other people, be afraid, or I may reject people before they can reject me. And that's an example of this interactive proximal stressor. I am going to change the way I respond to my environment based on my past experiences and expectations. And here's where Thomas Joiner's theory comes in. If I walk around with an expectation that I'm going to be admonished, rejected, dismissed, this is going to contribute to my likelihood of feeling like I don't belong or like I'm a burden to other people. That's going to contribute to this isolation that I might feel. And then, of course, habituation to the distal stressors and distress from unsupportive environments can be another contributing factor to suicidal thoughts and behaviors. And not only that, we do know that among LGBTQ plus youth, there is difficulty in vocalizing distress. Some youth may be concerned that they may not be believed or can't be heard, or others will become angry if they do speak out about their distress. And so that cuts off people even more. So we get caught in this very vicious cycle where the interpersonal concepts become interwoven with minority stressors and contributes to suicidal risk. So these are the factors that we need to be thinking about when we consider why there are these disproportionate rates of suicide in this population. So now I want to continue down a very specific road when it comes to social stress and discussion of social factors. As I mentioned, I'm a family therapist, I'm a family interventionist. And so I want us to talk about adolescents and many young adults' immediate context, which are their families. And for many of us, our immediate social contacts are our families, whether that's families of choice or biological families, adoptive families, extended kin networks. However we define families, they are very influential in shaping us. And for me as a suicide researcher, families are super important because we know that families are protective against suicide. We find over and over again in the literature for all sorts of populations that caregiver support is incredibly protective against suicide risk. We find that social support from caregivers predicts reduced suicide behaviors and increases help seeking. And this goes above and beyond social support from friends. And that's not to say that social support from friends isn't important, but we find that there is a potent impact when it comes to social support from caregivers, when it comes to youth suicide behaviors. And this isn't just for LGBTQ plus youth, but for youth across the board. And then we also know that caregiver support buffers against the negative effects of identity-related victimization. And this is specific to LGBTQ plus youth. And so this means that if a kid is experiencing bullying or stigma or abuse in other contexts of their lives, if they receive a safe place at home with their caregivers, if they can receive comfort from their caregivers, that can block some of the negative effects of what happens in the outside world. This goes back to our discussion about family as the immediate context. If we have safety in our immediate families, then we're going to be much stronger in being able to combat the issues that we may experience outside of our families. And then I want to get really pragmatic for a moment. When we have families on the team to help prevent youth suicide, this is more hands on deck for creating safety. And I do my best to engage families as a therapist because I know that if I can work together with caregivers, we can develop a plan to keep youth very safe in their homes. And that can reduce the need for outside supports and more intensive supports such as hospitalization or residential, if we can work with the family to be the safety net. So now let's talk a little bit more about family factors and challenges for LGBTQ plus youth. So first, I want to put it out there that conflict in families is normal in adolescence. Youth are developing themselves. They're developing their own values. They're developing who they are. They're using the family context to help scaffold that development. And so conflict is normal. Those of you who have adolescents are probably like, duh, yes, this happens. But when we find that families struggle is when pervasive conflict and relationship challenges are present in families. If we get stuck in the same kind of conflictual pattern over and over and over again and can't get out of that, that can create some problems. And for our LGBTQ plus youth, we find that depending on the families in which they live, they may be at risk for conflict with their caregivers, perhaps criticism and rejection. We find that the majority of caregivers eventually become more affirming over time after their youth comes out to them, but a significant portion, up to 40%, are initially rejecting, initially intolerant, or perhaps ambivalent about their youth's sexual or gender identity. And so for me, I'm curious about how do we access the protective power in our families, and particularly for LGBTQ plus youth, and also in those circumstances where caregivers start out as engaging in more rejecting, intolerant, or ambivalent behaviors. And just so you all know, I shy away from using terminology like a rejecting caregiver or an intolerant caregiver, because I see rejection and intolerance as more behavioral. We may have caregivers that engage in rejecting behaviors or intolerant behaviors instead of being completely intolerant or rejecting. So that helps us be able to work better with caregivers if we're working with the rejecting behavior instead of assuming that all caregivers are rejecting. Caregivers aren't that all or nothing. We see a range in acceptance here. So this slide is a little bit busy, but I'm going to just give you the core points. One thing that's very important to know is that there are very few therapy models that have well-researched for LGBTQ plus youth with suicidal thoughts and behavior. There are few well-researched models in general for suicidal youth, but in particular with LGBTQ plus youth. And this is important because as a therapist, it means something different to work with LGBTQ plus youth than it means to work with cisgender and heterosexual youth. It means something different to work with caregivers who may be engaging in rejecting behaviors than caregivers who aren't. And so this makes us very thoughtful about how we can shape our therapies to be most effective. And so there have been 2 therapies that have specifically focused on treating LGBTQ plus youth with suicidal thoughts and behaviors. And these are both very small studies. One is attachment-based family therapy, which we're going to talk more about today. And one is the affirmative group-based cognitive behavioral therapy, AFFIRM, which focuses on sexual and gender minority stressors by helping clients to recognize, understand, and change relationship between homophobic and transphobic experiences and feelings of stress, anxiety, depression, hopelessness, suicidality. So these are the 2 therapies that have received some adaptation specifically for this population. There are other therapies that I've listed here on the slide that are specific to LGBTQ plus youth, but they haven't really targeted or focused on suicidality in particular. So we won't be focusing so much on them today. However, if you're interested, I have recently published a review of therapies that you can take a look at. It's published in the Journal of Aggression and Violent Behavior, and you're welcome to reach out to me if you'd like a copy of that article. So now I want to focus on attachment-based family therapy and why attachment-based family therapy may be particularly helpful for LGBTQ+ youth. So what is attachment-based family therapy? So ABFT, for short, was developed by Guy Diamond, Gary Diamond, and Suzanne Levy in Philadelphia. It was developed in the context of the Children's Hospital of Philadelphia, where they treated hundreds of depressed and suicidal youth. And so I want to talk you through just the basics of what ABFT is. It's a brief family therapy. So what do we mean by brief? It means that the therapist works with the family for 12 to 16 weeks and is able to see some marked decreases in depression and suicidality after that period of time, according to our research. This is a therapy that was developed specifically for youth with depression and suicidality. ABFT has 5 interrelated but distinct treatment tasks. So what does that mean? It provides therapists like me a roadmap to be able to work with families and make change happen in a very short amount of time. When you're a therapist, it's very important to have a roadmap because there's a lot of things that are important that are happening in our sessions. Families have a lot of things to talk about. And so we need to make sure that we're focusing in on the most important areas to address suicide. So as such, this manual is focused, it provides a roadmap, but it is also flexible and allows therapists to ebb and flow and respond to the unique needs of our families. And it's based on some foundational theories in the world of family therapy and attachment, which is how we connect to other people in our lives and the importance of that for us. So here is a really, really important differentiation point between attachment-based family therapy and other types of therapies for suicidal thoughts and behaviors. So whereas other suicide treatments focus on behavior or cognitions and how a family might contribute to behaviors and cognitions related to suicidality, ABFT focuses on the quality of the caregiver-adolescent relationship as the primary mechanism for reducing suicide. So what are we saying here? It's not just about changing thoughts. It's not just about changing behavior. It's actually about changing the relationship between caregivers and adolescents so the caregiver can help the adolescent when they are feeling the most down, depressed, suicidal. So changing the fabric of these relationships is really the goal of this therapy. And we believe in ABFT, if we can make those shifts happen, families are much more able to cope with the stressors of daily life. And I'm going to talk to you more about how we get there in a moment. So long story short, caregivers and families are the medicine in this therapy. We don't want to do the work without our families in a therapy like this. So let's break this down. How do we spend our time in these 12 to 16 weeks of therapy? Well, we start out in our very first session talking about what we call the relational reframe. So we are asking our families, what stops the kid from turning to their caregiver for support and comfort when they need help? Let's really understand what gets in the way. How did that wall between the kid and the caregiver get developed? Or if there isn't a wall, what contributes to the kid being able to turn to their caregiver? So we want to understand how the kid accesses the caregiver as the support and why they don't, if they don't, because we want to seek to work together to solve that. Then we move on to what we call alliance task. So in this task, we are meeting alone with the kid. We are getting to know the kid. We're getting to know how their conflicts or disconnections or the wall dividing them from their caregiver has impacted their relationship with their caregiver. Again, it's all focused on the relationship here. We want to know why the kid isn't turning to the caregiver and get a really good sense of that. Now, at the same time, we're meeting with the caregiver individually. We're asking, what are the caregiver's own stressors? What are their histories? And how do they connect with their adolescence experience in the family? What do they think is getting in the way of their kid being able to turn to them? And how has that affected them as caregivers? We believe that if we don't get to know the caregiver, it's really hard to bring the caregiver on our team. We want to work with caregivers to make changes in the family. So after I've spent time meeting with the kid by themselves and the caregiver or the caregivers by themselves, we're going to come back together after a few sessions and help the family talk openly about what has gotten in the way. How do they feel about the relationship? Can the caregivers and the kids share perspectives? Can we get a better sense of what's going on for each other? And in this task, we really want the kids to be able to share honestly with their caregiver in a way that they haven't been able to do before. And then after we clear the air, then after we make sense out of disconnections in the relationship and talk about how to reconnect, we can move into what we call task 5, which is the autonomy promoting task. So can families build a strong youth caregiver relationship from which independence and autonomy can build? So once we have our caregivers and our youth connected and working as a team again, we can start to tackle the other hard stuff, like going back to school or getting re-engaged in soccer or taking on more responsibilities in the home or talking about the youth's future, employment, jobs, college, whatever that might entail. So we believe that we can do a lot more to help our kids and families if we can first focus in on that relationship. And we find for a lot of our families, once youth and caregivers feel connected again, that some of that suicidality, some of that depression is mitigated because we address, those concepts that Thomas Joyner talked about, thwarted belongingness and perceived burdensomeness. Kids are no longer alone. So this is a summary of attachment-based family therapy. So let's talk for a moment about the empirical support. Guy Diamond, Gary Diamond, and Suzanne Levy have done a lot of work to establish a strong empirical base for the model. ABFT has been shown to be effective in 6 different studies. It's on the treatment guidelines and the networks here in the United States and in other countries around the world because it does have that evidence base. But now what I want to do is talk very specifically about my line of developing research and the research that has paved the way for ABFT to be useful for LGBTQ plus youth in particular. So I'm going to be talking you through what I call the story of treatment adaptation. How did we change the model to make it work for our LGBTQ plus youth and their families? And then eventually, how did we change the model to work within the settings that treat LGBTQ plus youth? So our adaptation story begins in 2011 when Gary Diamond, who is now at Ben Gurion University in Israel, received funding from the American Foundation for Suicide Prevention to conduct a small adaptation study. So what did he do? He started out with some interviewing some sexual minority adolescents with reported depression and suicidality. So he met with them and he started to understand what were the key components of their distress. He met with 10 kids and really got into these interviews. He recorded them, he transcribed them, he pulled out themes. He really wanted to understand where they attributed their symptoms to. And he found in these qualitative interviews with youth that the quality of relationships with caregivers, issues of family rejection in relation to sexual identity, negative familial events related to sexual identity, and extrafamilial victimization like bullying and stigma, all these factors related to kids' experiences of depression and suicidality in this sample of 10 kids. And even more important, what Gary Diamond found was that results also indicated that these adolescents wished to have a closer relationship with their caregivers. They weren't saying to him, I'm done with my mom, I'm done with my dad. They were saying, I want to address these things in my family. I want to feel closer to my caregiver again. And so this adaptation study, this qualitative segment, these interviews led Gary Diamond to adapt the attachment-based family therapy flow. And so what he did is he changed the way that ABFT was done so that he spent longer periods of time meeting with caregivers to understand why they were engaging in rejecting behavior, what was getting in their way of engaging in more accepting behaviors. He developed pathways to help caregivers understand when they were saying hurtful things to their kid and how that got in the way of their closeness. And he helped caregivers and youth understand that acceptance is a process. Gary found that a lot of kids and parents were coming in viewing acceptance as all or nothing. So kids were saying, parent, you either accept me or you reject me. And caregivers were saying, my kid wants me to fully embrace everything about them, but I just learned about their identity and I'm not there yet. And so Gary slowed down the process so that parents and kids could recognize that acceptance needed to happen over time. And this helped them to give each other grace during the ABFT process. So after making modifications like this, Gary Diamond went ahead and did what we call piloting. So a small study where he wanted to see how this therapy worked. So he provided therapy to 10 cases, 10 sexual minority youth who came in for therapy for depression and suicidal ideation and or behavior. At the end of the 16 weeks of therapy, Gary Diamond found that suicidal ideation had gone down, depression had gone down to clinical significant levels, and that attachment anxiety or avoidance, which was a measure of the relationship, had improved. And so this was a small study, but Gary Diamond did find very promising results showing that these adaptations were indeed could be helpful for this population. And so later on, we kind of continued down this line of work of studying the impact of ABFT on LGBTQ youth, sexual minority youth. And this came through in a recent randomized control trial that was led by by Guy Diamond. And in this study, it was a very rigorous study. We compared attachment-based family therapy to what we call a non-directive supportive therapy, where therapists were meant to be a support, didn't provide direction on how the therapy went, but instead provided empathy and listening skills, and also provided psychoeducation to parents about depression and suicidality. So we compared two groups. Again, one was attachment-based family therapy, and the other was this non-directive supportive therapy with parent psychoeducation. So both strong therapies, but we wanted to see which ones did better. We ended up finding no treatment differences between the two treatments, but the good news is that everybody got better in depression and suicidality, no matter what group they were in. But here comes the interesting point. When we focused specifically on LGBTQ youth, sexual minority youth, we did find differences. And so what we wanted to look at were two things. So do our LGBTQ youth in the ABFT condition and the ABFT treatment, do they do better after the end of treatment? Do they have greater reductions in depression and suicidality? And how fast do they experience those gains? Because again, in therapy, we want to make sure that we're providing youth relief as soon as possible. So could it be that youth in the ABFT treatment improved more quickly than the other treatment? And so these were our results. So long story short, we actually found that our sexual minority youth receiving ABFT showed a greater rate of decrease in depressive symptoms than those in the non-directive supportive therapy condition. And this was interesting because our heterosexual adolescents showed significant rates of symptom reduction in both treatments. So there were treatment differences, but for our LGBTQ youth, there were treatment differences. They did do better in ABFT in terms of depression than our heterosexual youth. And not only that, they had a sharper decrease in depressive symptoms, meaning that they got better faster in terms of depression. No differences in suicidality, everybody got better, but there were differences in depression. So how do we make sense out of this? Why is it that our heterosexual youth did well in both, but our LGBTQ youth did better in ABFT when it comes to depression? This is the way we made sense out of it. In ABFT, we focused very specifically on the ruptures, on the disconnections between youth and caregivers when it came to sexual identity. We focused in on times when youth felt misheard, misunderstood, dismissed by their caregiver. And for many of our youth, it was about issues of sexual identity. And in our non-directive supportive therapy condition, we didn't specifically focus there. We talked about whatever youth wanted to talk about, what was important to them to talk about on that day. So the specific type of care we gave in ABFT, we recognized was particularly relevant for our LGBTQ kids. So all of this research positions us well to talk about my most recent funded study from AFSP. And that is, how does ABFT fit into our LGBTQ plus community centers? So what were the goals of this study? First, we were at a choice point. So as I said, Gary Diamond's work was only with 10 kids. That's a very small sample. We would be perfectly justified in wanting to do a larger study where we had 130 kids coming in and seeing if ABFT was effective for 130 LGBTQ plus youth. We'd be better powered. We can generalize the information in a better way, but we had to make a decision. And the reality is, and many of you probably know this, is that many of our LGBTQ plus youth don't present for clinical trial studies. Many of our LGBTQ plus youth don't present in community mental health. They're more likely to show up in affirmative organizations where they may be receiving gender affirming care or other specialized services that are designed directly for them. And so we had to decide, are we going to do another efficacy study where everyone comes into our center? Or do we need to start to think about how do we put this therapy out in the services that youth are already going to? And for us, we decided to go down that route. How do we get this therapy out there in the settings where people can actually use it and study it in that context? So instead of having an efficacy focus, which is, does this work or doesn't it work to reduce suicidality and depression, we decided to have an implementation focus. How do we adapt the delivery of this therapy so that it can fit within the context where youth are receiving services? So we wanted to get it out there and get the model accessible. So how is implementation science different from efficacy and effectiveness research? Again, it goes back to that question. Are we studying, does it work? Does it reduce suicidality and depression? Is that our only outcome? Or are we just studying and discussing the fit of the model in the services that are treating this population? And so even though in this implementation study, we are looking at suicide and depression outcomes, we're also looking at how do we adapt the delivery of this therapy to make it fit within this very specialized service setting. And so we had a couple different aims here. Our first aim of this study was to engage multiple stakeholders in the adaptation of the delivery of ABFT to meet the needs of multiple groups of people who are engaged in LGBTQ settings. So our multiple stakeholders were the patients themselves, the parents and caregivers, the therapists in these settings, and the administrators in these settings. Because we know in implementation science, if we don't talk to all these groups, if we don't engage all of these groups, then we're not going to be able to adapt or change a therapy in a way that's both feasible and acceptable to the community at large. And so it's just really important that we spend time hearing from everyone who's going to be involved. So then after we did interviews with each of these stakeholder groups, we did another small pilot where we tested attachment-based family therapy with 10 youth presenting in LGBTQ plus organizations, so we could evaluate if this therapy with the modified delivery was feasible, acceptable, and if it reduced suicidality. So I want to share with you a bit about these findings. So for our aim 1, we ended up conducting interviews with all of our stakeholder groups. We had 9 adolescents and young adults presenting for our interviews, 11 caregivers, 10 administrators, and 32 providers or therapists who were engaged in 3 different urban LGBTQ centers in Philadelphia. And so what did we find? What were the main takeaways? We found that LGBTQ plus youth reported mistrust of healthcare providers, particularly healthcare providers outside of the context of the LGBTQ plus centers. So this reaffirmed our focus on implementation. We really do need to get these therapies into the settings where youth are going to go. And this was due to experiences of discrimination outside of LGBTQ plus organizational settings. And this was a real problem because a lot of the providers in LGBTQ plus organizations, many of whom identified as LGBTQ plus themselves, were very hesitant to refer to psychiatry, very hesitant to refer adolescents and young adults to hospitalization or residential programs because they were worried about stigma in those settings. And so we often found that the therapists in these settings were overburdened and really had to weigh, how do I address suicidality and address risk, but at the same time, not expose youth to stigma? So that was a real challenge for these providers. When it came to caregivers, we actually found that a lot of the caregivers that we interviewed wanted to be more engaged in their child's care. They didn't want to sit outside the therapy room when the youth was having their treatment. They wanted to be involved in the process. And this was interesting because a lot of the centers that we were partnering with didn't have many opportunities for family engagement. And so we wanted to think about how and when and where and how and when is it safe to involve caregivers in their child's care. We found that providers in these settings reported varying levels of comfort assessing suicidality and engaging in empirically supported treatments. A lot of the concerns were that, if I do a manual, can I still deliver the therapy with authenticity? Can I still tailor it to clients' needs? And so we had to think about ways to talk to providers about the utility and flexibility of ABFT in a way that made sense for the kids they were serving. As I mentioned before, many providers felt unprepared to care for youth with suicidal thoughts and behavior because of that bind of my kid needs crisis or emergency services, but I know that they haven't had a good experience due to stigma and victimization in these non-LGBTQ plus services in the past. And then when we talked to our administrators, they were very enthusiastic about ABFT. They consistently cited a lack of psychiatric and clinical supports, particularly for this population. So our qualitative findings helped us to think about how to deliver ABFT in this particular context and how to make it fit with providers' values, which we'll talk a little bit more about in a moment. So let's talk about AIM2. That was the pilot, the 10 youth that we served in this study. So what we did is we recruited 10 adolescents and young adults, ages 15 to 25, and these referrals came from our 3 centers that we were partnering with, our 3 LGBTQ plus community centers. We measured feasibility, and this was measured by successful referral and treatment completion. So if people completed treatment, came to sessions, we saw that as feasibility and that families could more or less participate without too much burden. We also measured acceptability as alliance and confidence in treatment. So we had some questionnaires that asked things like, how is your therapy going? How do you like your therapist? Do you think your therapist likes you? Do you find this treatment helpful? So we can get a sense of both caregivers and youth's perception of the therapy. To assess depression and suicidality, we used a measure of suicidal ideation over the past month where youth could report their level of ideation. And then we also asked youth about depression, and we asked caregivers about stress. So let's talk a little bit about our findings. So we found that even though this was a new type of therapy and delivered in a new context, that our treatment completion and retention was high. All families completed all 16 weeks of treatment, and several families wanted to continue. So we saw them to 24 weeks. So we found that our feasibility was particularly high, and that families were able to come and engage with the therapy. We also found that youth and caregivers reported high alliance, both at the beginning of therapy and at the end of therapy. They liked their therapist, they thought the therapy was helpful, they felt respected by their therapist, and they liked the treatment goals. Opinions about treatment. We also found that for caregivers that our opinions about treatment were adequate at week 4, and these were maintained. And this was true for both youth and caregivers. So how did they feel about the therapy model, not the therapist? Was it useful? Was it valuable? Were they getting what they needed? And indeed, we had adequate scores on that. So now let's talk about preliminary effectiveness. I call it preliminary because it's really hard to get a true effectiveness sense from the data with only 10 kids in a pilot study. So we call this preliminary effectiveness. This just gives us an idea of whether or not we saw some results. So we found that more than half of our participating youth no longer endorsed severe suicidal ideation at the end of therapy. And that was a requirement for participation. Kids needed to express severe levels of suicidality to be involved in the study at all. And so we found that over half reported reductions. We also did some growth curve analyses. What are growth curves analyses? They help us understand how symptoms change over the course of therapy. So we found that throughout the therapy, there were significant decreases in suicidal ideation over the course of treatment. And we got measures of suicidality at the beginning, at the middle, and at the end. So this was change over those 3 time points. Though not significant, we found that depression was trending towards significant decreases, although it was not significant. We expect that if the therapy had been a bit longer, beyond 16 weeks, we might have seen significant decreases in depression, but we did not see that just in the 16 weeks. We also found that caregivers did not report significant changes in their own stress or depression scores, yet we did have those decreases in suicidality in their youth. So we found that interesting. And then finally, at the end, we did exit interviews with all the youth and all the caregivers to see what their thoughts about therapy were. And in these interviews, the majority of our cases reported high levels of treatment satisfaction, and parents and caregivers reported more capability, more capacity to be a safety net for their kid in a way that they hadn't at the beginning of therapy. So these are just visuals of what I just talked about when I use the word growth curves. This is how we map out changes in our different cases over time. And you see the red and the blue lines, those indicate trends. Remember, we had a significant decrease in suicidal ideation over the 16 weeks. And we had a decrease in depression, although it was not significant, but we expect that it may have been significant if we had more time. So what are our conclusions from this study? First of all, we found that ABFT is feasible and acceptable in this unique type of treatment setting. We were able to put ABFT in practice. Families did come to the treatment. They reported benefits from the treatment. Even in this small sample of 10, everybody came and completed treatment, and these were cases that were reporting high levels of distress. So even when families were distressed, even with a lot of stressors, we were still able to get families to come in. One thing to note is that the majority of our sample in this study were transgender and gender diverse youth. We did not plan it that way, though those were the referrals that were being sent to us by our collaborating agencies. And so whereas Gary Diamond's work focused on sexual minority youth, this work ended up focusing on transgender and gender diverse youth, gender minority youth. And not only that, we found that the majority of our sample identified as both sexual and gender minorities. So in that way, we had a very different sample than Gary Diamond did. And then we saw in this sample significant decreases in suicidal ideation over the course of treatment, but not depression. Why do we think that is? Well, again, it may be that we would have gotten significant results if we went longer, but we also have to think back to our sample. ABFT had not necessarily been adapted for transgender and gender diverse youth, which clinically, this population comes in with diverse needs than sexual minority youth. And so we may recognize that a 16-week treatment model may not clinically address the complex needs of this population. Many of my transgender and gender diverse youth in this study endorse severe gender dysphoria. And so we were working on that with families, and we might have needed more time. It also tells us that we need some more attention to treatment adaptation work when thinking about our transgender and gender diverse youth. And if we targeted this a little bit more and adapted it a little bit more, maybe we would have some significant changes in depression. So with that said, I want to tell you a little bit about the work that we are doing to begin to modify ABFT for trans-identified youth. And the model adaptations, we have drawn a title from one of our community partners. She calls it affirmative ABFT, and so we've adopted that name. So we wrote a paper about affirmative attachment-based family therapy, and this is a case study. This was one of the youth that we saw in this implementation study, and in here we talk about proposed modifications to ABFT specifically for this population, and walk through a case where we applied these adaptations. The family was very generous in letting us use some of their story for research. Of course, the names and identifying information are all changed, so nobody has any idea who this family was, but they allowed us to talk about the nuances of their therapy for the sake of training other providers. And so I want to talk with you all a little bit about those changes that we're thinking of to the ABFT model for trans-identified youth. So the first advice we have is in the name, affirmative ABFT. We believe that any kind of treatment approach with this population has to be founded in affirmative practice. What is affirmative practice? It means an acceptance and embracing of a youth's LGBTQ plus identity or identities. And every intervention we make solidifies that affirmative, accepting stance. This is more than just tolerance. You know, I accept you and I are different, or I accept you are identify in a certain way, but I'm not going to make a statement about it. Having an affirmative stance is making a statement. It is saying, I accept you, I embrace you, I want to learn more about you. And so in order to do affirmative attachment-based family therapy, therapists have to be affirmative first. And so when we demonstrate our affirmative stance to the youth and caregivers we work with, that allows us to build trust with them. And in a therapy like attachment-based family therapy, trust is key because we're doing really hard, vulnerable work together. We're repairing wounds that have gotten in the way of connection. And in order to do that, we have to be a safe, secure person. And so when we work with this population, we have to make sure that we're explicitly talking about our affirmative stance. And then in addition to that, we have several clinical recommendations to shape the way we do ABFT when we're working with transgender and gender diverse youth. And now that you know a little bit more about the attachment-based family therapy model, I'm going to talk you through some of these shifts in the approach. So when working with transgender and gender diverse youth, we want to start with the family task, the reframe task, as soon as we can. We want to make sure that we're able to talk about what gets in the way of the kid going to the caregiver, but we recognize that sometimes we need to start with the youth alone or the caregiver alone. Sometimes there's not enough trust built up to have that conversation together. And so we may need to start separately and work our way back together instead of starting together, doing our separate work, and then coming back together. The other is that a lot of our trans-identified youth come to us feeling very disempowered in healthcare settings. A lot of decisions have been made for them. They haven't had much of a say in their treatment. This is what we learned from our interviews. And so throughout the therapy, and especially in the beginning, we want to make sure that we're communicating respect for what the youth's thoughts and feelings are about the therapy and about us. And similar to this, in a lot of LGBTQ plus agencies, therapists and community workers often disclose their own sexual and gender identities to the youth that they're working with. When youth come, they want to know that you have a stake in their wellness. They want to know why you've come here and what your story is. And so sometimes as therapists, we have to move away from that blank slate kind of removed stance and talk to kids a little bit more about our connection to the work and who we are. We also recognized, especially when youth have first come out as trans to their caregiver, we need to spend a little bit of time educating caregivers about gender identity and the fluidity of gender identity. A lot of caregivers come to us feeling overwhelmed. And so that education allows us to build trust with the caregiver and allows them to lean on us for support and knowledge for the time being. We also find that when we're working with caregivers who may have a difficult time relating to the stressors their youth experiences on the basis of their sexual identity or gender identity, we may need to help caregivers recognize where they in their own lives have faced discrimination, stigma, or other issues, whether that's on the basis of race, whether that's on the basis of socioeconomic status. All of us have experiences where we have run into this. And sometimes when caregivers can get in touch with their own experiences, they can open themselves up more to relating to their kid. And we want to help them look at that. And then finally, we want to be talking to kids about how the disconnection with their caregiver may or may not be related to their sexual or gender identity or their coming out process. And so as a therapist, I get very curious about youth's coming out process and who knows and who doesn't. What pronouns do caregivers use with their kid? What pronouns does the kid prefer that I use? And is it different? And so I want to make sure that when we move into that time when we come back together, that I am preparing the kid to talk about their experiences with coming out, if it's relevant, and how their disconnection with the caregiver does or doesn't relate to issues of identity. And then finally, the end goal of all this work, of course, is to help caregivers and kids work more together as a team. And for my trans-identified youth, part of working as a team means that the caregiver learns to become an advocate and an ally of the kid. At first, as the therapist, I'm taking a lot of the advocacy tasks on myself. I'm calling the school and talking to the school counselor about what the kid might need. I'm calling the psychiatrist and educating them about pronoun use and what it might mean to be trans-identified. And so I'm taking a lot of that on in the beginning, but eventually when that relationship is stronger, I want to pass that baton back to the caregiver, because that shows that the caregiver is really wanting to build that connection with their kid and that the kid can rely on them. So in sum, those are some of the things we think about when adapting ABFT to trans-identified youth. And so I want to leave you with just one statement about future directions and where we're going with research for this community. So we want to make sure that we're continuing to build and study affirmative ABFT. And so this means that we want to do future clinical research to really hone, flesh out, and test those modifications that we made for working with trans-identified youth in this model. 10 cases isn't enough to tell us how this is working. And so we need some more work in that direction to see if it's effective. And then back to the implementation science conversation, we need to make sure that we are finding ways to partner with LGBTQ plus service organizations and talk about modifying programming, practices, suicide screening into their organizations so that we make sure that we as a community are providing a safety net for LGBTQ plus kids showing up in these spaces. And so this isn't just about continuing to implement ABFT across these agency settings, but it's also about working with agencies to figure out what tools and techniques are going to work best in their settings. So that's where we're going research-wise. And so if you take nothing else from this conversation, I hope that you'll take away the fact that it has been shown that caregivers are a very important presence in the lives of their kids, and this doesn't change when youth identify as LGBTQ+, and that we need caregivers, we need the whole family to help keep youth safe. So that was my presentation, and I'm happy to answer questions. Oops, I think I lost you on video for a second. Let me figure out what happened there, but I'm here, happy to answer questions.
While Jody fixes her camera, if you have any questions, can you pop them in the chat so that we can get to everyone?
You can also feel free to come off camera and share your question too, whatever you're comfortable with. And thank you, Jody, in the meantime, for that wonderful presentation. And, you know, as Meg said, it's just about the hopefulness of hearing about the research and the work being done and the passion you have to make a difference. So thank you.
Absolutely. I was talking to you, Meg, at the beginning. I also have a lot of hope for this line of research, and we're excited about moving it forward.
Does anyone have a question, a comment?
Mike Bushman has a question. Some of the kids and young adults removed from their homes by DCFS are sexual minorities. Is there a way to take the lessons learned in group homes that take in these kids and to test the lessons in these traumatized family situations?
Yeah, that Mike, thank you for that question. That's a really important question. First of all, I want to go back to the way that we define family in ABFT. We take a very broad definition of family. So I'm working with gay moms, gay dads. I'm working with older adult siblings. I'm working with foster parents. I'm working with adoptive parents. We are interested in building secure bonds with the caregivers and the family members that are accessible in the youth's life. And so for kids who have been removed from their homes and are in different spaces, we are working with them to be able to find that secure base who we can bring. I say secure base, it's an attachment term. Who can we bring into therapy who's secure, who's safe, or who can work towards being secure and safe? And so I encourage all providers and all community workers and all allies to think about family in an expansive way so we can consider the possibilities of who to engage in this type of work.
Hello, can you hear me?
Yes.
Oh, my name is Elizabeth Cherry. You can't see me. I just had to reconnect on my iPad. I put 2 questions in the chat. One question was, does this research include intersex? And my other question was, do the caregiver / the parent / the adolescents, are they introduced to the DBT skills early on? Mm-hmm. And the reason I asked that question is because had I had some of those tools, I think it's a good chance that I may not have tried suicide. You know, if I knew that I had the tools to change my thinking process, sure. Then with some of the skills that Marsha talks about in the DBT, yeah, I think it would make a difference. So that's my question to you.
Thank you very much. So first question is about intersex youth and including intersex youth. And the second question is about inclusion of DBT skills and some of Marsha Lenehan's work, which is wonderful work. I agree with you. So the first answer is we don't know if we had intersex youth in this study. And the reason we don't know is because early on in our adaptation process, when we started working with LGBTQ+ agencies, we did have a question about sex on our demographic information form, and our community partners told us that it wouldn't be such a good idea to ask about sex. They felt that sex and the nature of one's genitalia was private, and that we actually might distance people if we asked about sex instead of asking about gender, which is more of a psychological construct. And they said it to me in a way that made a lot of sense. They said, Jody, sex is between the legs, gender is between the ears. And so we decided to actually take our questions about sex, biological sex, whether one is male, female, or intersex, out of our demographic information form and just focus on gender for this particular study. But I think
Okay.
yeah.
Okay. Okay. I see where you're going. I'm picking up what you're putting down. But why can't intersex be included in LGBT/intersex?
Yeah. Oh, and that's a good question. And indeed it is. Intersex is absolutely included in this. And to your point, there's a lot of advocacy organizations and a lot of work focused on intersex populations. And there is a great need for resources. What I'm saying is that in this particular study, we don't know who was intersex and who wasn't. And as a researcher, I'm with you. I wish we knew that information so we knew if we were helpful or not. But our community agencies felt like that wasn't an appropriate question to ask for their kids at that time. So we followed their advice there. But I would say it's a really important thing to know. And intersex people are absolutely included in the LGBTQ plus umbrella as far as I'm concerned.
But if me looking at it, if I had no idea, if I didn't know about intersex, and I'm looking at the slides and the presentation and it's focusing on the LGBT community, then I wouldn't know that intersex is included had I not asked, because it's not within the label. You know what I'm saying? It's not within your title.
Yeah.
So again, I'm asking you why it doesn't say LGBT and intersex. So the audience wouldn't, me per se, I'm gonna speak for myself, that I would have known that it was included.
That's a really good point. And when we, I think the acronym is always evolving. And for me, the plus indicates intersex, but I do know, and in other areas, folks are using more of the LGBTQIA plus, and the I is intersex, but your feedback is well taken. And intersex is a population that is often ignored and very important. And so I will certainly keep that in mind when I present this in the future. And if you read my review, and I'm happy to put it in the chat for you, I do give a scope of where we are in the suicide treatment literature and suicide literature when it comes to intersex people. That is included in my written review, and I'm happy to put that in the chat for you. So you had one more question.
Yeah, I had the question about implementing the DBT early on. I mean, because if the thought controls the mood controls the thought. And if I want to relate to my caregiver or vice versa, I want my caregiver to relate to me, it all goes with our thinking process. You know, I heard you say about acceptance and some other things to be accepted, and I understand that. But if my daughter is in the LGBT community, and I wanted to reach out with her, and I knew what where she was going with it, or her way of thinking and my way of thinking, and how we can intertwine those two. You know what I mean? You see what you see where I'm going with it?
I do. And Marsha Linehan's work is incredible, and DBT has a lot of support behind it for both youth and adult communities. This study was specifically focused on attachment-based family therapy, which is a different kind of therapy, right. DBT. And ABFT has never been compared to DBT as of yet. So we don't know in what situations and why one would be better than another. And so I think that we're talking about apples and oranges here a little bit. And that's not to say that studying DBT is important. It just wasn't the focus of this particular study.
Got it.
Good.
Thank you.
Absolutely. And actually, you're reminding me, I never put my slides in the chat. So let me go ahead and put them there for you.
Okay.
And per your question, I'm also going to put my review in there for you that includes some discussion on intersex populations. But while I'm doing that, if anyone else has any questions, I'm happy to talk to you.
Courtney, while we wait for that, do you think you could put in the survey? And I'll talk about that while we wait to see if there's any more questions.
Yeah, go ahead.
We asked that everyone who attended fill out the survey that Courtney just posted. It'll also be in your follow-up email. This helps us create a program that is interesting to the community. So if you could take a moment, fill this out, tell us how we did, tell us what you want to hear about for our next Research Connection program, that would be a great help. And I don't see any more questions, so last chance. All right, thank you, Jody, so much for taking time to talk with us today. I certainly feel better knowing that there are advancements being made in suicide prevention, especially in this vulnerable community. So thank you so much.
Thank you so much, Jody. And thanks everyone that attended. We appreciate you being here and appreciate the great questions as well.
Thank you all.
Thank you.
Thanks, Jody.
Thank you. Bye-bye.
Nice to meet you.
Bye-bye.
Nice meeting you too. Bye.